Hello friends, hope all of you are doing fine. My name is Dr. Saif and you are watching Critical Care Academics, where I create videos for all the critical care trainees from any part of world. In today's session, we will be discussing the transpulmonary pressure, which is a critically important pressure, an essential topic for exams. TPP is a vital concept in respiratory physiology that represents the pressure difference or pressure differential between the pleural pressure, the pressure inside the pleural cavity, and the alveolar pressure, the pressure inside the tiny alveoli. So this difference is important pressure, which is known as transpulmonary pressure, the pressure across the lungs. And this is the true distending pressure. So mathematically, as I said, TPP is the difference between the intra-alveolar pressure and the pleural pressure. Now problem is how to measure these pressure. Very difficult. The theory is very good, but practically how to measure, clinically how to measure them, that's a challenge. So what we do is, as in case of heart, we assume so many things. We take a lot of indirect evidences, indirect measures. So in the same way, for the lungs we take indirect measures, but because what we can monitor and what we cannot, we have to connect these two things using our brain, and that is what physiologists have done. So for intra-alveolar pressure, because your sensor cannot reach to the alveoli, so what they have done is that they say that whatever you measure at the end of airway, that is at the at the mouth, at the level of mouth or at the level of trachea, that is the airway pressure. So airway pressure is equal to the intra-alveolar pressure. Okay, that is what they say. So in practice, what we do is to hold the respiration. So we can do that on the ventilator. We can put a patient on respiratory hold, respiratory pause, and during that time both inspiratory valve and expiratory valves are closed and there is no flow occurring in the lungs. So during this time, the pressure at the end of airway is equal to the pressure inside the alveoli. And again, this airway pressure can be equal to the plateau pressure, and pressure equilibrates after peak pressure, that you can see on this in this graph. So that time the plateau pressure becomes intra-alveolar pressure during respiratory hold. Now, how to measure pleural pressure? Again, it is difficult to directly measure the pleural pressure unless you do some invasive procedure. You can make an incision into the parietal pleura and insert your manometer. That we will talk about that later. I will show you what kind of manometer it is. But before that, clinically, less invasive method is available, or minimally invasive method is available, which is called esophageal manometry. Okay, so we put a catheter with a balloon into the esophagus. We inflate the balloon with some air, and this intrapleural pressure can be estimated indirectly because of esophagus anatomical position. So anatomically, esophagus remains inside the chest in the pleural space. So esophageal pressure serves as a surrogate for pleural pressure. Okay, so esophageal pressure can be an indirect measure of pleural pressure. So this is how we measure it, and then this formula, the plateau pressure is equal to alveolar pressure minus PPL, can be rewritten as P plat minus PES. Plateau pressure minus esophageal pressure becomes the transpulmonary pressure. So this is the way we monitor it. Of course, patient has to be intubated. For that, patient has to be nicely sedated or even paralyzed for measurement of plateau pressure and respiratory hold and all. And again, for the esophageal pressure, it cannot be tolerated by a weak patient or who's on an IV or high flow nasal cannula. It is quite cumbersome to do the esophageal manometry. So there are drawbacks. That's the reason it is not so popular pressure. Transpulmonary pressure has not come into the clinical practice. Only 1% of intensive care units across the world because of the challenges. Anyway, the most common method for estimating intrapleural pressure, as I said, is esophageal manometer. As you can see in this photograph which I have taken from this paper mentioned in the bottom. So the catheter equipped with a small balloon is inserted into the esophagus, and balloon is inflated with a minimal volume of air, And the pressure readings from balloon are used as a surrogate for pleural pressure. As you can see here in this figure, this is your esophageal pressure. Okay, so you take an average during the respiratory hold and then you just subtract it from the plateau pressure, or sometimes you can do it even at a time of end expiratory occlusion, but there shouldn't be any flow during the measurement of esophageal pressure, but it will be not accurate. However, direct measurement is possible using the pleural manometry during thoracentesis. If you put a catheter inside, then you can measure. Now, normal values for TPP are approximately plus 4 millimeter of mercury. So the pleural pressure is actually minus 4 millimeter of mercury. You can say intra-alveolar pressure is at atmospheric pressure, so it becomes 0 millimeter of mercury. So 0 minus minus 4 is equal to plus 4 millimeter of mercury. That is your transpulmonary pressure, which is important for distension of lung during inspiration. So this is your inspiratory TPP. So TPP can be inspiratory and expiratory both. Okay. So inspiratory TPP in spontaneous breathing is usually plus 4, and during expiration it can become 0. So during spontaneous breathing TPP, the inspiratory TPP is plus 4. Now during the time of pneumothorax, in the event of pneumothorax, it can become 0 or even negative. And under intermittent positive pressure ventilation, that is your mechanical ventilated patients, it becomes even more positive, because here we are giving high positive pressure. Okay, so usually it is plus 4 and it can go more than 3 times, so it can go up to 10 to 15 centimeter of water for the positive pressure ventilation for proper distension of lung, and still some atelectasis can occur. So that is the reason your expiratory TPP should be even positive. Okay, in case of spontaneous breathing it is 0, almost 0, but in case of IPPV or mechanical ventilated patients, your expiratory TPP should be at least 5 or even 10 centimeter of water. That is actually selected to select the PEEP on ventilator even. In acute respiratory distress, when the lungs get stiff, completely stiffened lung, in case of ARDS, when the compliance becomes too low, it becomes too hard to ventilate the patient. So too hard means what? You are actually increasing the elastic load, and your TPP may go even higher, more than 40, 50, 60 centimeter of water. Okay, so stiffer lung, higher inspiratory TPP. And there is something called transpulmonary pressure guided ventilation, which is even safer than P-plat guided ventilation. So here you keep the lung protective ventilation safe limit. So why do we need to monitor TPP? That is the question. Monitoring TPP is crucial because unlike plateau pressure alone, it provides more precise estimate of actual stress across the lung. Okay, independent of chest wall mechanics. This is a very important line. Independent of chest wall mechanics. Your plateau pressure takes into account both lung as well as chest wall mechanics. Lung elastance and chest wall elastance both are added when you calculate the P-plat. So P-plat is not a true distending pressure, lung distending pressure. So relying solely on plateau pressure can be misleading, and it can cause over distension, increasing the risk of ventilator-induced lung injury. As you can see here in this picture, TPP is inside the lung, across the lung basically, and P-plat is both lungs as well as chest wall. So TPP is more useful than P-plat in certain conditions like ascites, where TPP guided ventilation allows safe titration of PEEP and respiratory pressure both. So as illustrated by comparison table here, P-plat is airway pressure at the end of inspiration, and it is combination of lung plus chest wall load, elastic load, and transpulmonary pressure is basically alveolar pressure minus pleural pressure, and it is a true lung distending pressure. Okay, even clinical targets are different. There is 5 centimeter of water difference, and even during the end expiratory phase, you have a TPP target that is called end expiratory or expiratory transpulmonary pressure, which should be more than zero, ideally 5 to 10 centimeter of water in case of ARDS. As I was saying, that TPP monitoring is very, very important for titration of PEEP. It is one of the method. As you know, this is also a big topic. How to select best PEEP, how to select appropriate PEEP for patient who is undergoing an ARDS ventilation. So you have to know what are the ways to select the best PEEP. So this is one of the method where we adjust the PEEP so and expiratory TPPs more than zero up to 10 centimeter of water to keep alveoli open, especially in ARDS, to prevent the alveolar collapse or electrotrauma. During recruitment maneuver, TPP is useful because it will prevent the over distension, it will prevent the barotrauma, and it can improve the oxygenation by opening up the collapsed alveoli or flooded alveoli. Obviously, TPP has more value in lung protective ventilation. It ensures tidal volume aren't too high and reduces the lung stress. Last clinical application, that it can detect the patient ventilator asynchrony, various type of asynchrony like ineffective trigger, reverse trigger, etc. So we can monitor, reverse triggering, during which tidal volume is added up because of reverse triggering. Two times triggered, normal trigger, then again reverse trigger. The tidal volume is stacked up, leading to high tidal volume, as much as high more than 10 12 ml per kg, and it can cause over distension, barotrauma, etc. So these abnormal pressure rise can be detected using TPP, and you can use TPP to solve the problem of reverse triggering. I think this is also an important, interesting point. Okay, so TPP guided mechanical, this could be a short note. TPP guided mechanical ventilation, but using the transpulmonary pressure to optimize the recruitment, to optimize tidal volume, and to optimize the PEEP. This is your TPP, targeted mechanical ventilation. The text is written, and there is something called driving TPP or delta TPP. So that is the difference between end inspiratory and end expiratory TPP, which should be targeted. As per few studies, articles, they suggest a target below 10 to 15 centimeter of water. As you know, the driving pressure. In driving pressure, what is there? P plat minus P. So here we have a driving TPP, which is basically end inspiratory minus end expiratory TPP. It should be less than 10 to 15 centimeter of water, actually less than 10 centimeter of water, which is also a safe way to mechanically ventilate the patient in ARDS, avoiding the lung injury or VILI. So studies suggest that TPP guided mechanical ventilation can improve the oxygenation and also can improve the compliance. One more thing we can do is, this is a research area obviously, that we can prone the patient and then use the TPP guided. So how TPP is affected by proning. TPP has been largely underused due to all these cons, all these limitations. As I was saying, we relied too much on the assumptions, and then technicality is there to measure the pressures. That's the reason. So less than 1% patients with ARDS receive this monitoring tool as per lung safe study conducted in 2016, published in JAMA. So this was a large observational study, by the way, and everybody should be aware, should be deeply going through this article published in JAMA 2016. So there are so many artifacts which are possible, which can affect, like swallowing, incorrect balloon inflation, malposition, which can distort the readings of esophageal pressures and ultimately TPP. So you have to be very careful, even in correctly placing the balloon position, esophageal balloon, and regularly calibrating it, and interpretation has to be very careful. There could be chest wall heterogeneity, which can affect the pleural pressure. So as you know, the esophageal pressure may not perfectly reflect the pleural pressure in all the regions of lungs. So ARDS is a heterogeneous disease. So it can cause, and even it can cause the pleural abnormality, sometimes subpleural consolidations and all. So in those cases, it may not be reliable. So regional ventilation, regional perfusion, all those things are coming up from research to clinical practice slowly over a time. I think you will see more and more coming into picture, and critical care is going to be more complex. And that is where you have to use the AI to make it very simple. Otherwise, how will you remember? Limited availability is also an issue, and training requirement, patient discomfort when they are awake or less sedated. So it is not a routinely used monitoring gadget. It is only limited to the research so far. In summary, TPP is the difference between alveolar and pleural pressure, reflecting true distending force of the lung, eliminating the chest wall factor, chest wall pressures, or elastic load. Clinically, it can be very useful to guide the PEEP selection and to appropriately adjust the ventilator settings, tidal volume, especially to prevent barotrauma, overdistension, and safe limit. Everybody should remember is less than 25 centimeter of water during aspiration and more than 0 up to 10 centimeter of water during expiration. So that's all for today. Thank you so much for your attention. I hope this video would be very beneficial to all of you. Bye bye.